karyotyping. Obviously, Down syndrome, we are not going to go for exome sequence. These are some simple examples I'm telling you, but depends on your clinical diagnosis, we can do the genetic testing. The list is growing. Each and every time I'm doing a presentation, I will be adding one more testing. That means these labs are growing up. There are so many new diagnostic modalities are coming up every day. So we have to be very clear before ordering this. We cannot be carried away by what the lab persons say also. We should have some idea. Otherwise, whatever they are strong in, they will sell the goods and go. So cost, coverage, accuracy and fallacy is very important, because you are playing with the money of the patient. It is like a gamble. Most important is coverage. Not all the labs have the similar coverage. For one particular gene, one lab will be having 97%, another one 85%, another maybe 99%, we may not know. And accuracy of the lab, accuracy depends on the team who is reading the reports, the bioinformatics team. So it is not like I've done this testing in one particular lab, that is the end result. Results may vary with various labs, and inherent fallacy of the investigation should be understood before sending testing. Some genetic disorders you will be finding by sequencing, some may be from deletion of that particular gene. So you cannot expect the deletion will be picked up by sequencing analysis. So these are small things we should understand. And post-test counseling, based on the results, how we are going to counsel the family. So review the reports. Fine. Huh? So review the reports and counsel regarding the result implication. The results can be positive, negative or doubtful. Now particularly with various variants of unknown significance coming up, most of the labs, they give and get away. They give that report as viewers, they get away, wash their hands, but it will be our own responsibility to tell them whether this is truly the genetic abnormality for the patient or not. So mutation is identified, then it is fine. You've got a hold of the disorder. This is positive mutation. What are the treatment options? How it can be prevented in the next pregnancies? How I am going to take care of this child? All these answers are there in your hand. Anybody, the sibling can be tested also based on the reports. If the mutation is negative and you are very sure it is genetic, you may need to level up your genetic diagnosis to the next level. Maybe next differential diagnosis you have to consider, start doing the testing. And most of the time we are caught up with this one now, because the labs, they always they market a lot, they do so many testing, their hands are full, they get away with giving variants of uncertain significance. Very catchy situation. Physicians cannot tell whether this is the mutation or not. They cannot ignore this. They cannot take this as a diagnosis also. Patient will be very upset. We will be talking in so much of confusion we will be, so that will be transmitted to the patient also. Mutation doubtful, what can be done? If you are very sure this is not the mutation, this is not fitting with the phenotype of the child, move on with the next level of genetic testing. Maybe if you are convinced that this is matching with the phenotype of the child, then family segregation analysis. Maybe parents we can recheck and then finalize, or somebody else in the family is affected, recheck the mutation. If the same mutation is found, maybe this could be the reason. If the mutation is not found, obviously that is not the mutation you are looking for. Functional studies say this may be associated with lissencephaly. Go ahead, do MRI, find out, add some valid points to the mutation if you can. So all these cannot happen in one setting. That is why we need all these patients to come up regularly to us. I'll finish off with the evaluation part with the case scenario. So this couple, they are non-consanguineous. So family pedigree is normal. First one ectopic, and the second pregnancy, the feature suggestive of congenital severe lamellar ichthyosis, but it was found out by 31 weeks, because we cannot find out in antenatal scans before 24 weeks or even early, even 31 weeks it is difficult. Only with that echogenic debris of the amniotic fluid they found out eclabium, ectropion, suspected lamellar ichthyosis, and then they went ahead with termination of the pregnancy with official permission. Postnatal pictures were taken. It was suggestive of harlequin ichthyosis. Obviously, this is a severe most lamellar ichthyosis, severe most ichthyotic condition, and this is 100% genetic. So there is no other reasons going to give this sort of abnormality, and the parents are non-consanguineous. So what we did was promptly we took skin biopsy sample of that particular baby. So skin biopsy was taken and DNA was stored. This baby we advised autopsy. Family did not want it. We took a photograph and the baby was discarded. So we have a DNA, and then with that DNA we went ahead and did the whole exome sequencing. We found out a mutation, but again what we expect here is pointer. So we accept here is homozygous mutation in a autosomal recessive condition. You can see that it is autosomal recessive, but again it should be homozygous to cause disease. We know it is a autosomal, but heterozygous means it is a carrier status. Only one allele is involved. Other allele we don't know what has happened. So we have narrowed down to one particular gene, but we are not convinced because other allele the abnormality is not found out. Whole exome sequencing is not the end test result. So what we did was we did exon array. This is a test which will detect deletions in the gene which will not be picked up by whole exome sequencing. Exon array picked up other mutation in the ABCA12 gene which is in the other allele which is a deletion. So with this testing we have narrowed down to one gene, and then one gene, one mutation is found, that is a smaller deletion, almost a point mutation. Then we went ahead with exon array. This is a new test, and we found out the other allele is also involved. Now we got the diagnosis here. So one allele it is a mutation, other allele it is a deletion which was picked up by exon array. Obviously in an autosomal recessive condition both the parents should be carriers, and we found out that father and mother are carrying the mutation. Mother was carrying the point mutation, father was carrying the exon array abnormality. So what we expect from you is genetic disorders in the family have significant recurrences. Catch them early, refer them early if possible, particularly before planning next pregnancy. They have to come to us. Whom to test is index patient, and pre-pregnancy workup is the ideal thing. What we need is time to evaluate. Sick patients, anomalies, store DNA so that we can do the genetic testing later. Why is this genetic testing important? Already we have made a diagnosis. Why should I need a genetic testing? You are giving an answer to the family so that they will come out of that uncertainty. You can provide support to the family with family support groups. Unless you make a diagnosis, they cannot be included in family support groups like Down Syndrome Federation or ORDI or lysosomal storage disorders. Recurrence prevention, without the genetic diagnosis, it is very, very difficult to prevent recurrence in the next pregnancy by prenatal diagnosis. So management part, most important is this the right time? Right time. So management part, the concept is one gene is responsible for one protein or one polypeptide. So it means if a protein is defective, there is a gene which is defective. So because wherever the protein is needed, that organ will be affected. That is the idea. So treatment options are, you have to start from the gene. Either you have to go correct the gene, or you have to go give that protein which is not produced, or only you can do the end organ correction, end organ supportive care. So what we were doing previously is basically the end organ care. That is, if the baby has neurodevelopmental delay, cardiac abnormality, inborn as a metabolism, giving a diet, cardiac abnormality correction, neurodevelopmental delay, giving supportive care, rehabilitation, all these were carried out previously. All these are treatment only. But again, nowadays specific treatments are available now. So inborn as a metabolism, phototherapy, bone marrow transplantation, liver transplantation, even pancreatic enzyme supplementation in cystic fibrosis, all these are treatment options previously also available, but we were not very, very convinced because they are not going to give complete cure. The need for search for complete cure was going on, and in between we found out that intermediate product, that is enzyme replacement therapy, that came up about 10-15 years back, and past 10-12 years India it is available. It is not freely available, I am telling you. It is available for past 10 years, but again with limitations. So lysosomal storage disorders are the group of disorders where enzyme replacement therapy was possible. There are around 45 to 50 disorders, and this is the list of enzyme replacement therapy which is available. Gaucher, Pompe, Fabry, MPS certain types, and ASMD and Woolman's disease or NCL. Again, all these are not freely available in India. Most importantly, Pompe, infantile Pompe is what we see. Late onset Pompe also exists. Infantile Pompe, the babies deteriorate very rapidly, so that they have to be initiated on enzyme replacement therapy. So Myozyme is the enzyme which is available. We have few patients, and nowadays there are some source like Center of Excellence like ICH, you can apply and get it, or some ESI they support, ESI hospitals they support, Army, from Army side they support also, Armed Forces hospitals. So these are available, and if the patient can negotiate and go through any of these channels, this is very, very possible. And now new drug has come up for late onset Pompe also. So Pompe, we have a patient who is 2 years old now on enzyme replacement therapy. So she is reasonably doing fine. She's not completely all right, but she's able to walk now. We have prevented death at least. Infantile Pompe, she would have died within 1 year, but again we have prevented death. We made genetic analysis of the next child by prenatal analysis, and the next baby is normal. All these things can be done if you make a genetic diagnosis. You are treating the first patient, you are preventing next baby being born with a genetic disorder. Next thing is Gaucher's disease. We have enzyme replacement therapy. It is a multi-system abnormality. 3 types. Type 1 is more of hematological, thrombocytopenia, anemia, so they may present like that, and type 3 is neurologic Gaucher's. Type 2 is infantile, they cannot survive. So type 3 is most common in Indian population, neurological Gaucher. And we have a patient who is studying BCom now. He's been on enzyme replacement therapy past 10 years. He has Gaucher's. Without Gaucher's disease type 3, he would have gone for permanent neurological damage. Fabry's disease, another group we may not see. They present with in the adolescent group neuronopathic pain. So they may progress to acute renal failure. This is a X-linked recessive. Males will be affected. So we have enzyme replacement therapy. We don't have patients, but few of other centers in South India, they give enzyme replacement therapy for Fabry. We don't have a patient with us. So MPS, various types are there. And most important is, as early as possible, you have to diagnose the type, apply for the mutation, apply for the enzyme replacement therapy. It definitely will improve the quality of life. And for prevention, obviously genetic analysis has to be done. MPS type 1, type 2 is available in India. Type 4 and type 6, it is very, very difficult in India. We have not got it, but there are enzyme replacement therapies available because we don't have tie-up with these companies. They are not ready to give us. Type 1 and 2 also, they are giving free of cost. It is only by charity we are able to give. Nobody is able to afford for this because it costs around 50 lakhs per year. So these are the treatment options. Type 2, Hunter's disease also, we have enzyme replacement therapy. Beauty is, you start early, they will behave exactly as a normal child because you are giving that by intermediate product, the enzyme which has to be produced in the body, we are giving. Like the thyroid, we are supplementing from outside, you are going to give the enzyme replacement therapy. They are related, they are doing very, very fine if we start early. Only thing is diagnosis and getting the treatment for these patients. So it will definitely reduce the organomegaly, number of episodes of sleep apnea, urinary gag. Almost they will live a near normal life with enzyme replacement therapy, but again it has to be given lifelong. So there are few charity options available, but each patient we have to negotiate what are all the ways for them. We will look forward and do that. And spinal muscular atrophy, a very new one, wonder drug like 16 crore medication. All these are sensations nowadays, but they present with severe hypotonia in infancy. Type 1 is the commonest. They have this deletion in exon 7 and 8. Depends on SMN2 copies. Types will vary from 0 to 4. 0, they are not going to survive fetal form. 1 and 2 maybe childhood. 3 and 4 maybe adulthood. And 1 and 2, 1 is dreaded. They cannot cross 1 year. So previously, and even now, this is the supportive care, that is adequate nutrition support, adequate vaccination, making sure their lungs are fine, making sure muscles are functioning well with supportive therapy till they get the medication is what we were doing previously. That has to be continued even with medications. 3 options are available. Nusinersen, Spinraza, intrathecal medication, FDA approved. It has to be given by spine. 1 crore per year is the cost. Risdiplam can be taken orally. It is a Drug Controller General of India, DCGA approved medication is this one, and it has to be given lifelong again. This will again abort the progression of the disease. Zolgensma is the 16 crore medication, and then it costs around 16 crores for one medication. It may last for 10 to 15 years. So correcting the actual defect is by gene therapy. That is possible with Zolgensma, where it goes and bridges the deletion itself. So I'll move on. How is this possible? Is through the AAV9, adeno-associated virus vector, through which the vector will carry the gene. It will go invade the DNA. It will correct it so that the gene is corrected in the cellular level. So only few slides, I'll finish off. The key here is you have to make diagnosis early, because every day the delayed diagnosis or delayed treatment, most of the muscles will be damaged. It cannot be brought back. So the child will be in that same situation. It may not deteriorate, but again it may not improve also. Keeping a child lying down forever with the medication is not so, not what we want actually. So we have a patient who is under risdiplam medication, oral medication in our setup. Type 2, he is doing reasonably fine, not completely fine, he is doing reasonably fine. We are giving with charity only, free medications only given. So Duchenne muscular dystrophy, exon skippings are coming up, exon 51, exon 55, exon 53, exon 45, all these are exons skippable. If these exons are there, before that if the deletion is there. So depends on the deletion, where the gene's deletion is, exon skipping is possible. Now these are under FDA approved in outside other countries, but in India we are able to only recruit patients for trials, dosage trials like that. Patients are getting some remedy, some medications, but not like commercially it is available. Treatment for hemophilia, so many medications have come up. Achondroplasia, we have biomarine compound. If it is given, definitely they are going to improve in height. Comparatively without growth hormone and biomarine is going to give a great improvement with height. Osteogenesis imperfecta, we are giving zolidronate nowadays, and fibrodysplasia ossificans, we have medications available, that is palavertine is available, and these are treatment options available. So take home messages are not rare, genetic disorders are not rare and not treatable also, because now they are manageable and supportable. That is what we were doing previously. Now we are justified in managing and supporting them, because ultimately we are moving them, we are preserving them till they get a treatment. So previously treatment now you support till they get the treatment is the idea. So early diagnosis, timely intervention is very, very important. Delay in diagnosis is equal to irreversible damage. So start doing genetic evaluation, which may give idea about treatment and also prevention. Gold standard treatment is not easily accessible to Indian population. There are diagnostic challenges, hurdles in treatment are there, particularly with the medications and the late diagnosis. Recurrence risk is very, very severe. If you can't treat something, you can definitely prevent. That prevention is in our hands. Maybe treatment is not in our hands now. In future, it may change. So preserve till they get the medication. That is the idea now. So prevent the genetic disorder in the next pregnancy, that is with us, and preserving these patients till they get the medication is in our hands. So try to do that. Thank you so much.